Guys, it's Chelsea. I'm going to be talking to you guys about Optiflow, also known as high flow oxygen, and how it can be utilized inpatient. They're actually probably using a lot of Optiflow right now with COVID-19 patients, and I'll kind of get into that later. But it's good to know what exactly Optiflow is and does. So, the overview of Optiflow is that it's a non-invasive device which warms and humidifies high-flow nasal cannula, air, and oxygen blends, which are then delivered to the patient. The warmth and high humidity means that very high nasal flows can be tolerated. Um, with heat and humidity, it prevents airway loss, or airway water loss, airway cooling, thickened secretions, nasal irritation, and bleeding. The Optiflow allows delivery of breathing gases heated to body temperature at 100% relative humidity through nasal cannula without the airway drying or cooling. By contrast, flow from a bubble humidification system is well below body temperature and has a significant water deficit. So here's the product itself. You can see how it plugs into the oxygen device on the wall here. And then this is the device that raises the temperature and provides the humidity. And then this tube here leads to the nasal cannula that goes directly into the patient's nose. What's great about Optiflow is it enables high flows to be delivered directly into the nares, but patients are still able to talk, eat, drink, wear glasses, they can cough, they can maintain their own oral care without having to remove a face oxygen mask every 2 seconds to do so. It's also been shown that patients are more compliant with Optiflow than with alternative therapies, so they're more likely to keep a nasal cannula on than they are a full oxygen mask, and I think we can kind of all relate to that. And the idea of Optiflow was to design it with comfort as a priority for the patient. So making it as comfortable as possible makes it more easy to fall into compliance with. It also improves mucociliary clearance, which I'll get into in a minute. So here are the uses for Optiflow. Basically, the effects of heat and molecular humidity optimize the use of the nasal cannula, allowing higher flows to be used. It provides the ability to deliver high flows without adverse effects and patient discomfort. So before I mentioned nasal drying, bleeding, and septal breakdown, plus everything I said before. It's especially useful in the NICU environment because the Optiflow allows practitioners and family members to easily feed, hold, and care for patients. Studies indicate that recipients also take slower, deeper breaths at high flows. Patients are encouraged to extend their expiratory phase as they breathe out against the high flow. They also tend to have reduced respiratory rate with no change in PaCO2, indicating that tidal volume may be increased with reduced dead space. Airway drying leads to, so this is the mucociliary clearance. So when an airway is dry, it leads to poor mucociliary, sorry, I can't say that word, transport in patients with both like COPD, bronchiectasis, increasing exacerbation frequency, and decline in lung function. So studies are actually showing that breathing fully saturated gas at body temperature significantly improves mucociliary clearance. As for contraindications, sorry about the creepy guy over here. It was the only picture I could find that was like of a face surgery. Anyway, sorry. He's really creepy. My bad. Contraindications or complications are pretty rare in adults, but they include abnormalities or surgery of the face, nose, or airway that preclude an appropriate fitting nasal cannula. So, like, you're not going to put this on a patient who has severe facial burns or who maybe has severe swelling. Some experts avoid Optiflow in those following upper airway surgery to avoid the theoretical risk that the high pressure may precipitate a venous thromboembolism. So, since the definition of an acute respiratory distress syndrome, or ARDS, is dependent upon calculating the partial arterial pressure of oxygen to a fraction of inspired oxygen, so PaO2 compared to the FiO2 ratio. Some experts have raised concerns that the recognition of ARDS may be adversely impacted by Optiflow because improvements in oxygenation seen in mild ARDS with Optiflow may result in a PaO2 to FiO2 ratio below the threshold of diagnosis without having accounted for the positive and expiratory effect of Optiflow. So, but it is important to keep in mind, however, that this is a theoretical disadvantage and it may be mitigated by the potential beneficial benefits on improving ventilator-induced lung injury and thereby the progression of hypoxemic respiratory failure to ARDS. The patients that we're really using Optiflow on is mostly to provide a relatively high FiO2 to patients with severe non-hypercapnic hypoxemic respiratory failure. And we kind of know that as acute hypoxemic respiratory failure from medical causes. As an example, in a randomized trial of 15 patients with severe hypoxemic respiratory failure, so their PaO2 to FiO2 ratio was less than 300 mmHg, and then their mean PaO2 to the FiO2 ratio was 130 mmHg about, which is low. When compared with oxygenation via face masks set to the same FiO2, patients with Optiflow actually demonstrated improved oxygenation, a lower respiratory rate, and decreased minute ventilation. Tidal volume was unchanged, which is not super important, kind of important, although end expiratory lung volume and an estimate of dynamic lung compliance increased. Optiflow has also been employed as an adjunct support measure in patients following extubation. So I've got a little picture over here of someone being extubated, which is not comfortable, I imagine. As a means of helping the patient adjust to no longer being extubated, Optiflow has also been used successfully in the treatment and prevention of postoperative respiratory failure. Most experts use conventional systems, which include the high-flow oxygen masks and low-flow nasal cannula, and a bag mask ventilation to deliver oxygen prior to intubation. The bag mask or oxygen mask is temporarily removed, sometimes leaving cannula in place for the intubation procedure itself. And even though it's not technically routine, Optiflow is an acceptable way to provide oxygen to patients undergoing intubation, both before and during the procedure, to prevent desaturation. Importantly, no delay in pre-oxygenation should occur while waiting for Optiflow to be set up. So that's why they typically go with the more common methods, and because Optiflow takes a few minutes to set up. And so the idea is to provide pre-oxygenation using other available means in the meantime. And that's it. I hope you guys learned a lot. I hope you're staying safe. And I probably won't see you anytime soon, but I hope all is well. Thanks, guys.